Good evening, and thank you for joining tonight's online briefing with Congressman Jayapal. We'll be getting started momentarily. Thank you for joining. Thanks. With Congressman. We'll be getting started momentarily. Thank you. Good evening, and thank you for joining tonight's online briefing with Congresswoman Jayapal. We'll be getting started shortly. Thank you.
Start the video.
Good evening, everyone, and thank you for your patience. Welcome to tonight's online briefing with Congresswoman Jayapal and Alex Greninger, Dr. Alex Greninger from the University of Washington. Before I turn it over to Congresswoman Jayapal, please note that you can submit questions on the Q&A if you are participating via Zoom online. And with that, I will turn it over to Congresswoman Jayapal.
Good evening, and thank you so much. Thanks for joining me at this unprecedented and challenging time for our community. I know there is a lot of heartache and anxiety out there, and the purpose of this briefing is to try and just continue to share as much as we can about what's going on, what we're doing, and to answer some of your questions that you've been sending in over Facebook and Twitter and online. I want to thank Dr. Alex Greninger. We are just so incredibly fortunate to have Dr. Greninger here at the University of Washington lab doing the work that he is doing and honestly lending expertise across the country on exactly how we're tackling this here at the University of Washington, here in Seattle and here in Washington State. So thank you, Dr. Greninger, for lending your time to us tonight. Over the last few weeks, our region has been at the epicenter of the COVID-19 pandemic in the United States. When I hosted my last teletown hall just 8 days ago, we had 162 cases in Washington State and 423 nationally. There were over 4,000 people on that call, and we were able to answer some of the 120 questions that we got. Sadly, we've seen the number of cases across the country rise rapidly, and we are now in the middle of a global pandemic and a state of national emergency with more than 1,100 confirmed cases and 67 deaths in Washington state and more than 7,000 cases nationally and 97 deaths nationally. I know, as I said, that this crisis has caused great anxiety and uncertainty. I know many of you are home with your kids. I know many of you are looking after your elders and your parents that are in your family, and you're worried about how we're going to get through. We will get through this, and we'll get through it together. And my role is to try to provide you with regular updates, get as much information out to you as possible, and then tell you what I'm trying to do in Congress and update you on those actions that we're taking in Congress to mitigate the harm of this virus, to ensure public safety, and to shore up our workers and our economy. And I also want to use these calls to just update you on the latest guidance from public health officials that will help keep us all healthy and safe. Before I do that, though, I just want to express my condolences to the family and friends of those who have lost loved ones. My heart goes out to you. And I also want to express my appreciation to everyone that has been involved with the response: the city, county, and state and federal public health experts, the frontline healthcare workers and first responders who have been working overtime to respond to cases, care for the sick, and protect our region, to the workers who continue to do the work, whether it's our garbage collectors or our grocery store workers, the people that are out there continuing to do work because we need those things to continue to happen. To each and every single one who has stepped in to help those who are hurting right now, thank you so much. You are showing the world the sense of community that makes me so proud to be your representative in Congress. As you know, our local, state, city, and county leaders have taken swift measures to slow the spread of the virus. And because we're first, everybody's been looking to us. All the schools in Washington are closed now through the end of April. And earlier this week, Governor Jay Inslee, who has just been a phenomenal leader for us in this time, and King County Executive Dow Constantine restricted gatherings of more than 50 people until at least the end of March. Smaller gatherings are also prohibited unless the CDC or Washington State Department of Health, Public Health, and the social distancing guidance is followed. Bars, restaurants, clubs, gyms, and other social gathering places are all shut down at least through the end of March. The ban does not apply to pharmacies or grocery stores at this time. And generally, I would just say gatherings of any size are highly discouraged. I'm sitting here in my home today. We are practicing what we preach. Both of our offices are teleworking, and we are doing everything we can to continue to serve you, but also keep our folks, our staff safe, but also anybody else that is out there that's vulnerable. I know these are very challenging restrictions, but they will save lives. And so I thank you for making these big changes to your daily lives for the greater public good. Governor Inslee has also issued multiple emergency proclamations today to help provide relief to workers and businesses, as well as renters and residents who are negatively impacted. Today's actions from the governor include a statewide eviction moratorium for 30 days, an order to give the Washington State Department of Revenue the authority to waive interest, fees, late payment penalties, and due dates for a broad range of taxes, and that is retroactive to February 29th, the date that the governor declared a state of emergency here in Washington. It also included waiving the 1-week application waiting period for unemployment insurance, because we know how incredibly important that is to people. And then expanding eligibility for the Family Emergency Assistance Program, which is cash assistance, to now include low-income families without children. So those are important steps that the governor has taken, and also our city has taken some important steps that I'll mention later. We are very grateful to the governor, to Dow Constantine, and to Mayor Durkin for all working together, working with the congressional delegation to do all we can at every level. In terms of how we are responding in Congress, we passed an $8.3 billion relief package that was 2 weeks ago, was signed by the president. and it addressed the needs of particularly our public health departments that desperately needed assistance so they could continue to do what they were doing. Just after midnight on Saturday, and that bill was passed by both the House and the Senate and signed into law by the president. Just after midnight on Saturday, the House passed the Families First Coronavirus Response Act, which was our second piece of emergency legislation to address the emerging needs of the coronavirus epidemic. We are still waiting to see what changes the Senate is making and what the president ultimately signs into law. But I will go through just a couple of the things that that piece of legislation included. The bill did include free coronavirus testing for people who are, for a vast majority of people who are, including those who are uninsured or underinsured. I will tell you, I'm disappointed that it did not include testing for certain categories of immigrants, including undocumented immigrants, DACA recipients, and legal permanent residents that have been here for less than 5 years. We are working to get that fixed right now because what we know is in a public health crisis, making sure that everybody who is sick and with this virus is able to come forward and be tested without the costs of that testing. We also included in the bill another important priority that I championed alongside many of my colleagues on the House Education and Labor Committee, and that is increased funding, more than $1 billion for food assistance for several nutrition programs, including SNAP, student meals, seniors nutrition programs, and food banks. We also included paid emergency leave with 10 days of paid sick leave, and for certain categories of workers, up to 3 months of paid family and medical leave. I will tell you that this provision as written in the original House bill was far stronger, and it was unfortunately weakened by Republicans in the House and potentially weakened more in the Senate. So we are trying to shore up that paid leave for everybody, and we can give you more details on exactly who is covered and how much they're covered till once we see the final bill. We enhanced unemployment insurance in our bill that we passed, and we increased federal funding for Medicaid to support local, state, tribal, and territorial governments. So there is a lot of work to do, even to fix some of the provisions in that bill that we hoped would be stronger. But we are already working on a third piece of legislation that we hope we will pass next week that is really going to be an important stimulus for individuals and working families across the country. And so some of those steps that we are pushing for as co-chair of the Congressional Progressive Caucus, but also as senior whip of the Democratic Caucus, we are pushing to try to include direct cash support to the most vulnerable, including gig workers, independent contractors, and low-wage workers. We know that there are a lot of these folks that have not been covered by the bills we've passed. We are aware of that, and we're trying to get cash support directly out to people as quickly as possible. We also are putting together a much more comprehensive package for small businesses. I had a call with many of our small businesses in the district yesterday. It was heartbreaking. These small businesses are the heart and soul of our communities and our economy, and many of them are trying to keep their employees whole, and even as they deal with potentially shuttering down. And so we know that loans are not enough, that there need to be direct grants, that expanding unemployment insurance is critical for many of these folks that may not be covered, and also expanding the amount of unemployment insurance. And we also know that we need to look at making sure that rent can be covered, utilities, some of those other expenses that don't just go away for small businesses. And I would include nonprofits and arts organizations in that. The third area we're hoping to do some more work on here is protecting the most vulnerable within the prison system and the immigration detention centers. This is very, very important to me and to others in our caucus. And we think we should be not only ensuring treatment and testing, but we should be actually getting folks out of immigration detention systems that don't need to be there, the most vulnerable populations, and using alternatives to detention in both situations. We are working on issuing and clarifying specific provisions related to the treatment of immigrant communities. And we're also looking to invest in childcare during these school closures and other educational needs to ensure our kids get to stay on track and graduate. And finally, we are working on a number of higher education provisions that we hope will include some level of loan forgiveness during this crisis for many of our students who have student loans outstanding. So that's just a short list. I'm also calling for a federal moratorium on evictions and foreclosures and other housing assistance, including an infusion of resources into service providers and cities and towns that are assisting persons who are experiencing homelessness. These issues predate this pandemic, but in a lot of ways, they've been brought into focus in recent days. And tomorrow, I will introduce a comprehensive bill, the Housing is a Human Right Act, aimed at supporting those experiencing homelessness. That bill would invest significant federal dollars in providing emergency services, as well as an infrastructure to expand shelter and permanent housing. And it would push back against harmful narratives that treat people experiencing homelessness as less important or less deserving of help. This week, I also joined a few of my colleagues to call on mortgage lenders to halt foreclosures. And so we're hoping to include a number of pieces of that bill into any legislation that we move forward. Here in the city of Seattle, Mayor Durkin and the city council have taken swift and bold action. They've put a moratorium on rent-related evictions, provided vouchers for families to buy food and household goods, and opened up funds to support creative workers and arts organizations. So we are pioneers on bold progressive solutions for working people, and we are going to make sure that that tradition continues. In Congress, my colleagues in the Washington State Delegation and I are continuing to push to make sure our state gets the resources that we need. One of the critical areas has been our PPE needs, our personal protective equipment for our frontline workers and our healthcare workers. And so I led a letter along with Representative Jamie Herrera Butler and a bipartisan group from our state delegation to the Department of Health and Human Services Secretary Alex Azar, and it was urging him to expedite the supply of that PPE. Last night, I spoke to the Assistant Secretary of Health and Human Services, and he has expedited, based on our call, that our request for PPE. So we're hoping we get that very, very soon. Last week, I was also able to get a top-level DHS official to guarantee that the administration's horrific public charge rule, which makes immigrants afraid to seek medical care, would not apply to seeking care for COVID-19. So that is important. It is now on the DHS website. And we know it doesn't take away all the fears, but we hope that it helps a little bit. There is even more that we're doing that I will touch on later, but we are so fortunate to have with us a real expert and innovator and pioneer with our own Dr. Alex Greninger from the University of Washington School of Medicine. Some of you may have seen a really terrific Seattle Times article from Monday. The title was "How Intrepid Lab Sleuths in Seattle Ramped Up Tests as Coronavirus Closed In." And that article featured what Dr. Greninger and his colleagues have been doing. Thanks to them, the University of Washington has conducted more than 4,000 tests. And I am just so grateful for their early leadership, and that Dr. Greninger has generously offered some of his time this evening to speak to you and to take some questions. So with that, let me turn it over to you, Dr. Greninger.
Thanks, Representative Jayapal. My name is Alex Greninger. I'm an assistant professor here at the University of Washington Medical Center, and I'm a laboratory medicine specialist. So I specialize in laboratory testing, which has become very germane here for this coronavirus. So here at the University of Washington Medical Center, we came online early with a test now more than 2 weeks ago. We've done actually more than 14,000 tests so far. We do about 2,000 a day right now. That's sort of our current capacity, though tonight we should bring on an additional instrument, and over next week, additional instruments that allow us to get up over 3,000 tests per day. Unfortunately, we are detecting more than 120, sometimes 150 cases of COVID-19 every day here in our clinical lab. Really, I mean, testing is very important for peace of mind, for being able to allocate healthcare resources and isolate individuals who have COVID-19 and prevent onward transmission of the virus. It's also important to protect our healthcare workers, our healthcare labor supply, our first responders, and other vulnerable populations, especially those in nursing homes and assisted living and other institutionalized populations. Those populations actually have been sort of prioritized by the Washington State Department of Health and here at the University of Washington Medical Center as well. So we're trying to expedite testing for inpatients, people who need supportive care for getting test results faster, so we can conserve that personal protective equipment that Congresswoman Jayapal mentioned earlier today. With that, I mean, I'm happy to take any particular questions you have about coronavirus, clinical symptoms of coronavirus, and testing of coronavirus specifically, especially here in the Seattle area. I think one of the most important public health measures, of course, other than washing your hands, you're trying to avoid touching your face, is to basically, in all the social distancing measures, is be sure to call ahead. If you develop the most sensitive symptom for this condition, for COVID-19, is fever, and then followed by cough. These are non-specific symptoms. And so if you develop a fever, to call your healthcare provider, your healthcare system, and they usually actually have special COVID-19 related phone trees or people waiting to answer your questions, to screen and then to decide whether there's testing needed or what the best thing to do is. So I mean, just don't go straight into a clinic and present to emergency room unless you absolutely need supportive medical care. But I want to focus mostly on your questions tonight, and so I'm happy to take any questions you have. Thank you for having me.
Thank you so much, Dr. Greninger. So I want to start with just a couple of medical questions that have come in tonight and over the last few weeks, and you were just starting to get at a few of these things around what to do. So here they are, sort of four. I'll give you four of them. If I've been exposed to the coronavirus, is there an incubation period? If you have had COVID-19, can you be reinfected? If someone has recovered from COVID-19, are they still carriers of the disease, and can they still affect other people? Is there a level of immunity that you want to talk about? And then what do we know about the impact on older folks as well as younger people? And I can go through each of those one at a time if you need me to repeat them.
That's okay. Thank you. I appreciate it. So yes, coronaviruses, as all viruses, have an incubation period after you've been exposed to the virus. I think one of the most difficult things about this particular coronavirus is it actually has a kind of a long incubation period. It's been stated sort of unhelpfully that it's 1 to 14 days. That's a very broad range that's not really operationalizable, but it does. 14 days is sort of the maximum length that will sort of follow you for specific symptoms after you've been exposed. So after your 14 days, usually you're sort of in the clear. I think it's helpful more to think of it around like 5, 6, 7 days. The other stat that's really important here is that after you you have symptoms for this virus, after people become symptomatic with the virus, they develop that fever. They don't usually develop shortness of breath or symptoms that cause them to present for medical care until maybe 6 or 7 days as well, right? And so what that means is that, this whole time, many of the cases, when we detect a case, that usually is when someone is presented for medical care. And so if you go back 7 days for when the symptoms occurred, and you go back 7 days for when the incubation period occurred, you're starting to talk about detecting cases that transmissions happened 14 days ago, which is why it's been so important to be very proactive with these social distancing measures. And that's really what's going to bend the curve here. It's a very difficult virus to sort of just do contact tracing and isolate to be able to follow that up, because the cases are so from the past. If you've had COVID-19, well, and also to your question on incubation periods, we don't really know right now the best time to test. I haven't seen that in terms of from an incubation, if you're exposed, we'll swab you. And we have people we've tested, 3 or 4 or 5 times if they have specific symptoms. We try to go just with one specimen for each person. But right now, if you've been exposed, that's a reason to potentially get tested. But we usually like you to have a symptom like a fever, and then that is a good reason for a test. If you've just been sort of exposed, we might be swabbed, we'll get a negative, but we'll still be having to swab you again later. So it's better to kind of wait for at least a few days. If you've had COVID-19, can you be reinfected? The answer to that seems to be no. The ability people develop immunity against this virus, that's how they recover. And so, that immunity, this virus is very young. It's only been in humans for about 4 or 5 months now. The genomic diversity is actually quite limited overall for the one that's spreading in humans. And so there's not much diversity to allow it to become reinfected. It's really not going to happen. You could create a situation where distantly it might, but it really is not something that happens. So that immunity will cause you to be not reinfected. The one thing I will say is because of the virus can be in different parts of your respiratory tract, it can both be in the upper respiratory tract and the lower respiratory tract. You sometimes see stories of quote unquote reinfection, but really what it is that the person was tested positive, then they later tested negative, and then it tested positive. And really what it was is the same virus. It just, they did have that negative result in between. They do end up not swabbed, gotten as good of a sample during that negative. I don't think it's a reinfection. So if someone has recovered from COVID-19, are they still carriers of the disease, and can they affect other people? So if you've recovered from COVID-19, it's very unlikely that you will transmit. However, you still can shed virus at low levels. I think there was one paper that showed that you could have shedding up to 21 days. And this is known in other respiratory viruses as well. And so that's why I think the CDC for release from isolation still wants 2 negative swabs. Though they might update that guidance, but basically to be really sure that you're not still shedding virus at a low level. That said, it's not really clear how much of it's a major force in transmission, but certainly we can still detect the virus even after people for maybe a week after they've gotten better. And that's really, that's true with really any virus, honestly. Your immune system has worked its ways, protected yourself, but maybe there's still some virus and some mucus or something like that that can still be detected. And as you said before on the reinfection, there's definitely a level of immunity. And I think that's going to be really important for us to have tests developed that we can test for immunity, as this virus right now in a pandemic will likely be with us for a while. And we'll need to know, who has been infected, especially if there are these asymptomatic cases that can happen. We need to know, did you have a case? And that'll be helpful for peace of mind and to be able to follow and protect other individuals. And then the most important thing about COVID-19 is really its disproportionate morbidity and mortality among the elderly. This virus really is not found in young people. You can look at the statistics. Obviously we don't test as many young people for this particular virus as we do in the hospital. There's a little bias in the data that we see from, any place, Washington Department of Health as well. But only 2% of the cases in Washington State have been found among people under the age of 20. Very, very few cases in children. There's almost very few cases in children. The cases in the elderly, though, unfortunately, if you're over 60, it's a good reason to consider being tested. When you have these symptoms, you'll have a higher priority for being tested. The morbidity and mortality, the hospitalization rates, the mortality in some of these studies, especially among people over 60, is quite significant. And that is really the main issue, is that the virus is able to transmit among younger, healthy people. They get ill, and some of them do present to the hospital, but it's really among the older individuals. You saw that with the Life Care episode in Kirkland, and a lot of fears in nursing homes and assisted living facilities, and a lot of preventative measures being taken now, which is appropriate to prevent that from that virus from introducing to those communities where it can have very, very high morbidity and mortality. We say high, we say really relative to other respiratory viruses. That's really what we're comparing to. I mean, I think I will couch it in what Tony Fauci said, that it's sort of 10 times worse than the flu, maybe even more, honestly.
Well, let me just follow up on that. We have a question from Katie on Facebook, which says, "Are there positive cases without fever?" And I would just maybe expand that to something you and I were talking about before the call, just in terms of, are people potentially transmitting without having symptoms? And then also, when you said the virus doesn't exist, or I forget how you said it, but you said something about the virus isn't there in younger people. Isn't that partly because we're not testing a wide enough population, and that perhaps the negative effects that we're seeing in vulnerable populations is certainly not there in younger people, but part of that is because but in terms of the presence of the virus, it can be there in the full population. Is that accurate? Or
Yeah, but I will say though, I mean, even when we test in younger individuals and kids, we don't find it. I mean, the hospitals, the pediatric hospitals that send to us do not have. I mean, we really have almost no cases from them. I mean, so yes, absolutely. From an absolute case number in Washington State, there's probably disproportionate testing among older individuals. We've already said it's a reason to get tested. Or preferentially tested. So there's more tests being sent, we'll find more cases. But even if you just look at the rates of positivity among different hospitals that we see, the pediatric is much, much, much lower. It's actually really quite significant. There's definitely some biology there that we just don't completely understand, but need to figure out. I forget exactly what the first question though was that you asked. I apologize.
Sorry, because I threw in a second one. Katie from Facebook asked, "Are there positive cases without fever?"
Yes, so there are. Again, I want to hit the high points though here, which is that fever is the most sensitive symptom. All right, in some reports, original reports out of China, some I think at 98%. I've heard, different statistics for clinical in different populations between 80 and 98%, and cough is down there about 2/3 to from about 70 to 80% have cough. So it's really the fever that's the most sensitive symptom. That you see that in the screening of airports and other places around the world. That they're really looking at temperature first rather than sort of asking for lower respiratory tract issues. But it is true there are those cases that don't have a fever. But again, it's relatively rare. You would need to you would need to have like shortness of breath or some other reason to be tested.
Great. Here's another question from Facebook. It's from Jason. "I've read both that COVID-19 is spread only via droplets, but also that it can be airborne. Can you tell us which it is?"
Yeah, I think that there's some mixed data on this. I mean, so we typically talk about droplets when we talk about almost all respiratory viruses, honestly. Droplets basically means that it's something physically that's going to, it actually literally means it's going to drop, like it's going to fall. Gravity has its effect on that particle. Airborne means that it sort of is so small that it floats in the air, and it's not just like it's falling just because of gravity. So it's able to stay sort of buoyant in air in a way. I did read, I've been so busy here in the lab. I did see something about more data on airborne, on potentially, longer distance spread. I think this is one of those areas in transmission about viruses, especially respiratory viruses, that is just not as well worked out as we'd like it to be. I mean, we talk about staying 6 feet away from each other. I mean, 6 feet is good, 8 feet is better, 10 feet is better. I mean, right? Like these things are going to sort of actually scale probably by a square or more of the radius of how far what you are away, right? And so I think, from a precautionary principle, those sort of distances, are something you want to be aware of. But right now in the hospitals, we're still focusing mostly on droplet spread that I've seen.
Okay, great. We have a number of questions around testing. A number of our constituents have asked about how quickly we'll have universal access for testing in clinics, hospitals, drive-throughs, and ensure that testing and treatment are available to everyone, even if they're uninsured. Can you share anything with us about what you've learned through your work at UW? And then also, there was a question here about the sensitivity and specificity of your tests, and you might want to just talk about that as well.
Okay, cool. So, all right. So right now where we are at in sort of the, so King County, Seattle area is right now we are one of the University of Washington Medical Center is one of the major test providers. And as I said, we're doing about 2,000 tests a day right now. We're hoping to get up to about somewhere around near 3,000 by beginning of next week. That's our goal. And then we'll keep going by 1,000 a week, every 10 days more, adding on that capacity. So that's been real strain just on physically processing the specimens. We've got research volunteers from across the university coming in to help process those specimens. We just bought another floor in this building where we're at to where we can continue to process specimens and open up a special lab. And we're getting multiple high throughput analyzers that have recently been given emergency use authorizations by the FDA. For right now, we've been running what's called a laboratory developed test. It's a little bit more manual that we do 2,000 a test a day on. And that's really hard to scale that process to get up to 5,000 tests a day. That's what we can do here. That's what we're doing here at the University of Washington, but we're not the answer to everything. So there are other hospitals.
We think you are.
Oh, I don't bet that. No, I don't. There's so many people. It's been such a great team effort, honestly, at the University of Washington and across all the hospitals here. So we're actively sending samples out to help people validate these tests and these other platforms. And the FDA has allowed a lot more emergency use authorizations to come through in the last week. This week we've seen Roche, Hologic, Abbott, LabCorp, Quest, other big reference labs have. Those are some real big guns when it comes to being able to get instruments that are already in labs. And so it's really then about shipping the kits. And so we're actively trying to get those kits. We're getting more. We got more today. We'll get more tomorrow. Other hospitals will be able to have those instruments and be able to provide their own testing. So to answer your question, I'll put my nickel down. I think, from a I don't know what a universal testing sounds like, but what I think will be in a much better place in 2 weeks. And I think it really in sort of 3 to 4 weeks will be in a much better space. But I think there's still just there's so much demand for testing that it's hard to know exactly where the right population is still to test when that comes on. But our first job here is to expand capacity, right? So then we can sort of take those limitations, some of the limitations. We'd like to be testing more outpatients right now. We really would. And so taking off those limitations is required. First, we have to have the supply. We know that there's a lot of interest and need for testing. But I said before, right now we're prioritizing inpatients, people who need supportive care, healthcare workers, first responders, and institutionalized populations. And we're also prioritizing this geographic area. So, King County, Snohomish County, and Pierce County, those are our top counties. They're our top tier. People from hospitals from those areas have a much shorter turnaround time here in our lab. But it's really going to take the whole community of hospitals and clinical labs to bring on testing for this. And then there also, I'd say also the big national reference labs, so Quest and LabCorp, still are offering testing. It's tough. They're big national chains, so it's hard for them to meet all of the demand of the country at one time, and so their turnaround times can be like 3 to 4 days. But those are also options for outpatient testing currently here, and they're still accepting samples. We haven't heard anything about them saying they're not able to.
So while we're on testing, here's a question from Instagram. I'm concerned about access to testing because my doctor advised that even though I'm symptomatic, there isn't access. So the only solution is complete isolation, which I'm adhering to. Do you have you've sort of addressed that this person would be able to, at some point, be able to get tested, but anything else you want to add there?
Yeah, I think they can get tested. Sorry, we accept outpatient specimens. I wouldn't actually question the medical provider or whatnot on this. I think that it is helpful to get the message out to medical providers that there is access to testing, again, at Quest, LabCorp, University of Washington Medical Center. The turnaround time may be 48 hours to 72 hours. It may not be overnight, may not be that same day. But we do have access to that testing. It just sort of, I think this is true with many respiratory viruses where where we don't have a treatment, it's sometimes there's still a logic right now, like, oh, well, maybe I won't send a test. But for this one, we are really actively testing. So I think that there's the opportunity. I want to go back. You asked one of the questions that was in that previous question
about
was
the sensitivity and the specificity of your
right.
test, right?
So we talk about two types of sensitivity and specificity. We talk about analytical sensitivity and specificity, and then clinical sensitivity and specificity. So analytically, basically talk what happens, right? So you go to a healthcare provider, you have fever and cough, they put a swab into your nose that goes sort of the back of your throat, called a nasopharyngeal swab. And they put that swab in 3 mL of liquid, and that swab is sent to the lab. And first, we basically make sure it's exactly your specimen. So there's no specimen swaps or any problems in the pre-analytical phase. We take that specimen, we log it in, we send it to our lab here, and we take some of that liquid from that tube, put it in a different tube, so it can be nucleic acid can be extracted from it. And then we run what's called a reverse transcriptase RT-PCR reaction on it, which allows us to sensitively detect the RNA from the virus. And almost all the tests out there are looking at 2 parts of the virus. So they're actually quite sensitive and specific. The analytical sensitivity and specificity of our tests has been really excellent. We've been working actively with our state public health lab colleagues. They're actually totally open for testing too. If you want to, there's a message there. Their turnaround times are down to, under a day and a half. So they're doing quite well as well. So there's opportunities for testing the state public health lab. And they've been really helpful to help us come online. And our tests, we actually run the same test, the CDC-based assay, and it's a good test. It's a really good test and has a high analytical sensitivity and specificity. And our testing has been entirely concordant to date, which is something I think we're both proud of. So we haven't had any bona fide false negatives or false positives from an analytical stand. For another question though is a clinical sensitivity and specificity, which is how does this test relate to coronavirus disease? And there, one of the issues can be that, as I think I said before, the virus can be sort of in different parts of your respiratory tract. So it starts in the upper respiratory tract, and then it can go into your lungs and become a lower respiratory tract infection. That's where a lot of the morbidity comes from. So most of the specimens that we get are from swabbing your nose into your throat, or through your throat, oropharyngeal or nasopharyngeal swab. We can also test lower respiratory tract specimens, so sputum and then bronchoalveolar lavage. The state will do bronchoalveolar lavage. We can do sputum. The state will do any of these guys. And so, I do think there's an angle there, and there's definitely been reports. This is an active piece of sort of debate. I think it's been settled that the best sample to easily sample and process in the lab is a nasopharyngeal swab.